Very good evening, everyone. A warm welcome to each one of you to the ENDOSAFE Panel Discussion 2025, proudly presented by KAHO in collaboration with ASP. I am Ms. Meenakshi and I feel truly privileged to be your host for this session. Endoscopy has become a cornerstone of diagnosis and treatment in modern medicine, but with that comes the responsibility of ensuring the highest levels of safety and quality. Today, through this discussion, we will explore challenges, innovation, and best practices in endoscopy safety, bringing together the wisdom of experts who have worked extensively in this space. Now, to formally set the stage, I will introduce the program chair, endoscopy, the program co-chair, the moderator, and our esteemed panelists. Dr. Parivalavan Rajavelu is a consultant surgeon, Sundaram Medical Foundation, Chennai, founder Skills for Med Training Center, and the program chair of ENDOSAFE. Ms. Dhanya Michael, General Manager Quality, Rajagiri Hospital, Aluva, co-chair ENDOSAFE, and who will be the moderator for today. Dr. Chandrashekhar J. Sorake, Head of Department and Senior Consultant, Department of Medical Gastroenterology, Justice K.S. Hegde, Charitable Hospital, Mangalore. Sir is also one of the panelists today. Dr. Deepthi Madhu, Consultant Microbiologist and Infection Control, Head Apollo Adlux Hospital, Ernakulam. Ms. Barnali Banik, Senior Manager Education Solutions, Advanced Sterilization Products, India and Southeast Asia. With that, let's move forward to the heart of today's program. We begin with a brief introduction to ENDOSAFE by Dr. Parivalavan Rajavelu. He will take us through the objective, scope, and significance of this initiative in improving the safety and improving the safety and quality of endoscopy practices. Over to you, sir.
Thank you, Meenakshi, for that introduction, and really glad to be part of this program. Again, KAHO has been pioneering several such initiatives, and I think endoscopy safety is probably a very special one because I don't think anyone has really focused on this particular topic. So let me share my presentation. Are you able to see it?
Yes, sir.
Okay.
Yes, sir, we can.
Thank you. So ENDOSAFE stands for endoscopy safety audit and facility evaluation. Just 1 minute. Let me. Yeah. And so that's an acronym actually. If people haven't missed it, it is endoscopy safety audit and facility evaluation. That is what ENDOSAFE stands for. And we actually, started last year, and we released this manual, which specifically, has the standards for endoscopy units and specifies the standards. So this really raises the bar for endoscopy facilities in India. So why did we think about ENDOSAFE? So we needed a comprehensive audit program that evaluates endoscopy facilities, especially in terms of safety and quality. Though we have accreditation bodies like NABH, GCI, and other bodies, they actually, endoscopy is there, but not, really talked about as other particular departments which got a fair share of representation in these accreditation manuals. So we thought that this is something which is a niche area where we have to there is a scope to improve the quality and safety. And again, it covers quite a broad range from patient safety, infection control, staff competency, facility design, and of course quality assurance practices. And we also made that process to be pretty simple, where the facilities will go through a self-assessment, and then we would have a webinar to mentor these facilities on the various standards and objective elements of the ENDOSAFE manual, and then they get ready for the physical audit, following which the scores will be published. And it is a very outcome-oriented project where the aim is to make hospital endoscopy facilities as centers of excellence all over India. So that is why the ENDOSAFE was launched. And why did we do that? Again, it is there's a lot of variations and standards in India. You would know that tertiary hospitals probably got the state-of-the-art centers right down to standalone units, which just consist of one room, endoscopy units. So there's a huge variation. And how do we standardize this? And in addition to that, there are rising volumes, the complexity of the facilities and also the equipment is going day by day. And as parallelly, the risks of patients undergoing endoscopy is going up as well. And also, though there are published global best practice guidelines, there is a lot of variability in how this is being implemented across the country. So instead of adopting some Western standards, Kaho thought it was good to bring an India-specific, practical and adaptable solution, that is ENDOSAFE. So as I told, it is a very comprehensive program, and it covers all these aspects. And the benefits, as we have seen in the last 1 year, the first beneficiary is the patient. So if you raise the quality and the safety and tighten the processes and the facility design, it reduces the risk of complications and also the onset of infections. I think the main problem with endoscopy units is the reprocessing area, which has again got a lot of variability. And by using stringent objective elements, we could actually bring down the infection rate, and it promotes best practices. So, there is a bar now, there is a benchmark which is set by ENDOSAFE, and now hospitals and facilities can aspire to reach that benchmark. So, this what it does is standardizes workflows and procedures across facilities. It could be tertiary, it could be secondary, it could be a standalone. It does not matter. The benchmarks are the same. And as I told, the infection rate should now come down. We don't have actual data, but we are actually, in the process of getting that, and probably in another couple of years, we'll be able to share that with everyone. So the benefits to anybody taking this particular project is, first, it builds institutional credibility. We were really happy to see photographs of EndoSafe, framed along with the NABH accreditation in various endoscopy facilities. So definitely, the Kaho EndoSafe increases the credibility of the institution which is providing these facilities. And the manual is a continuous improvement tool. You can refer to it at any point in time, and it provides tools. And we also do frequent webinars which provides mentorship for people who are doing the endoscopic facilities. So all in all, it helps the healthcare teams which provide the endoscopy services in the hospital. So if you're wondering why I should choose EndoSafe, it's not a marketing pitch. I think it's just telling you that what EndoSafe offers. It's not just the manual, but also a well thought out plan which handholds you right from this meeting to probably the end of February, by which the EndoSafe audit will end this year. And this happens on an annual basis. So you get expert guidance by empaneled auditors and to address gaps. So we already have about 50 plus empaneled auditors, and we have actually are in the process of empaneling more experts, because we are expecting more and more hospitals to sign for EndoSafe. And all the standards have been carefully crafted based on the multidisciplinary guidelines. So therefore, if you follow this, then definitely you will be aligned with the international standards. And no, at the NDSAFE, as I told you, the outcome is to certify hospitals as centers of excellence or accredited centers. So this is a recognition of excellence any center would get if they go through the EndoSafe certification. So to summarize, EndoSafe ensures patient safety, establishes benchmark standards, fosters best practices, recognizes excellence. So every CAHOCON the best hospitals all over India have an opportunity to come on stage and receive the ENDOSAFE award. So we recognize excellence in compliance and performance and drives continuous quality improvement by such webinars and provides implementation support. So what are the timelines for this year? This is the first contact where we are doing the orientation webinar as of today. Then in October, the date will be announced. After all, the September 30th is the last date for registering of hospitals, for applications for hospitals to apply for the ENDOSAFE program. So once the 30th September deadline is done, then we have a cohort of hospitals which are ready for the audit. So then we will do a chapter-wise orientation webinar for these hospitals in October 2025. And then we will have a physical audit of registered hospitals happening from November onwards till end of February 2026. And end of February 2026, the scores are finalized. And in the Kahokon Chennai, this year it is in Chennai, in April 2026, we have the ENDOSAFE Awards, where the best hospitals in India for this year will be recognized on stage. So the audit methodology, as I already pointed out, is first a self-assessment. You'll be given a self-assessment kit, which you'll use to assess, and also using the manual as a reference guide. Then you have a period of 30 days or even 90 days, depending upon when your how quickly you do a self-assessment. And you would address the gaps and implement the ENDOSAFE standards, attend the mentoring sessions for continuous guidance, and then undergo the on-site audit, which is half a day, where it's a physical audit, on-site audit, where people, auditors will come to your center and audit you in person. So the audit criteria are based actually on the 6 chapters in the book. Facility design, looking at layout, workflow, streamlining, clean, separate, and separate, clean, and contaminated areas. Looking at patient safety protocols, infection control. Main emphasis is on reprocessing and sterilization. And then how well are you training your staff and the competency levels and quality assurance processes. So it's basically both looking at the structure and the process of endoscopy units in a very detailed manner. So the recognition is 2 types of recognition, as I already pointed out. It's either an ENDOSAFE accreditation, depending upon the percentage of marks you get, or a designated center of excellence if you are very close to the 100% benchmark. So if you get below a certain percentage, then you don't get accreditation or excellence, but you have a reapplication opportunity to go through the audit the next year. And when we give the certificate of excellence or accreditation, it is valid for 2 years, after which you need to undergo re-evaluation. Thank you so much for your kind attention. So that was a short curtain raiser on ENDOSAFE. Thank you so much.
Thank you very much, sir, for your wonderful insights. May I request our moderator, Ms. Dhanya, to take the discussion forward?
Thank you, Meenakshi. A very good evening, all. To warm us up, let me pose a broad opening question to our panelists. So from your perspective, what is the current state of endoscopy safety in India today? Dr. Chandrashekhar?
Yeah, good evening, Dhanya. Hi. Good evening to everyone. I think the biggest challenge we are currently seeing from the Indian perspective in terms of endoscopy is there is really no standardization that we are seeing, whether it is coming to training, now training for the doctors or training for the technicians. That's a big challenge that we see. And even in terms of the procedure quality, there are no standard protocols. Now, like as a gastroenterologist, performing endoscopy, we follow certain protocols like examining the stomach, certain time spent. So these are all certain standard protocols that are not being broadly followed. Also in terms of documentation, reporting, reprocessing, these are all, even in terms of the types of the equipment that is used. So currently, I think it varies from center to center. and because of which there is a wide variation that I have noticed in terms of endoscopy in India, even in terms of sedation and other aspects. Yeah.
Very relevant points, sir. Thank you. Dr. Pari?
Yeah, I would like to look upon. I think Dr. Chandrashekhar has told a very valid point. And so the one aspect I wanted to highlight is again the variability, which again I mentioned in my presentation. So we have these really state-of-the-art facilities. Now I recently went to a center in in a small place, Tanjore in Tamil Nadu, where there is this hospital which has got probably one of the best centers in endoscopy. And the same place would have a freestanding center, which is just a single room with no demarcation. So this variability is a huge challenge. Now, how do places, and both are needed. We need both in India. We need this accessible freestanding centers and also these tertiary centers, which are both necessary. And how do we adapt the standards to these two broad ends of the spectrum is again a huge challenge. So I think that is one thing, and because the facility design is the infrastructure. So once you built it, it is very difficult to change it. I mean, many hospitals I know have dropped out of ENDOSAFE because they say, no, I don't think we will do the justice, because we don't have that infrastructure. What you're asking, you're saying clean, contaminated separately. So how do we we are also evolving. As you know, in any standards or accreditation has to evolve, like how NABH started and now it's in the 6th chapter. I think ENDOSAFE also has to evolve. So now we have the first edition of ENDOSAFE just says do this. But I think in another 2 years when we revise it, I think we really need to look at how are we going to address these two ends of the spectrum, and that is the challenge.
Thank you so much, Dr. Pari. That's exactly the reason why we have ENDOSAFE program being designed today in our country. And Dr. Deepthi, we would like to hear from you.
Yeah, thank you, Dhanya. Thank you for a very valid question, and happy to be panelist in this group. So as Dr. Chandrashekhar said, and as Dr. Pari sir said, there is a lot of variability between centers. There is a lot of subjectivity rather than objectivity when we look at endoscopy or the endoscopy unit through the general accreditation norms. There are a lot of accreditation bodies, there are a lot of accreditation programs available in our country nationally and internationally. But take any of those accreditation standards through that periscope. When we look at endoscopy, there is a lot of subjective variability. There is a lot of room for subjective variability within the general accreditation standards. So that is exactly the reason why we need separate defined endoscopy program, because it looks into the nitty-gritty and takes away the subjectivity and makes it a very objective way of looking at it. And that is why even if you are assured that you have a very good endoscopy unit, you should still go for the program. And if you think you do not have all your ducks in a row, then also you should go for the program, because this assures a learning curve. It takes you along with you in the growth. So this program, I think, or endoscopy programs or certification programs will help in fine-tuning the system of a present in endoscopy unit, which cannot be automatically attained by going through accreditation programs.
Yeah, I just want to add
Exactly.
to that, Dhanya, because
Yes.
I think all our auditor training focuses on saying that get more centers onto the program. Don't exclude, include. So that is the main message we tell the auditors. So I think because we have to get onto the journey, get more centers onto the journey. I think that's very important. I think Deepthi made a very valid point there.
Exactly. And most of the accreditation program still have not specified this, as a particular chapter or any area. So much of stress is not being put at all. Very interesting perspective, Dr. Deepthi. Now to Madam Barnali, we would like to hear from you.
Yeah, thank you for all of you for putting in the perspective. I agree on this. And what the other element which I see is, even in state-of-art endoscopy units, what we see is there is a huge gap in understanding how the department should function. And here I'm not calling out specific to us to one of the chapters which Parisar just put across, the six chapters. Even when you see the competency of these people out there, and Dr. Chandrashekhar very rightly put across, right, that even when it comes to clinicians also, they at times don't understand what needs to be rightly done. So this is a gap, because most of the time what we see is it is more of on-job learning that they acquire on how to manage the entire department. And so this is a challenge. And here what I see is ENDOSAFE basically ties all the knots and brings a process in front of you which covers up every aspect, right? Obviously the training comes up to be a very critical. You know it, but then you don't have the expertise in you. You do have the skill, but the knowledge is also very, very important.
Thank you, ma'am. So all of us agree on one aspect. Most of our accreditation standards do not specify clear or dedicated requirements for endoscopy. That's why exactly we have this ENDOSAFE program developed, as it addresses the critical gaps and which is truly the need of the hour. So to our participants, we have a set of interesting Kahoot questions coming up shortly. Request everyone to stay online till the end. You have exciting prizes awaited as well. So now, building on this, let me turn to Dr. Chandrashekhar. Based on your clinical experience, sir, which is one blind spot that teams often overlook, whether in process or in physical infrastructure of endoscopy unit?
Yeah, Dhanya, shall I just cover that during my presentation, or do you want me to answer that separately right now?
You can answer it, sir.
So I think one of the biggest blind spots I felt in terms of in endoscopy was the gap between before high level disinfection. When the procedure is completed and before the scope then goes in for high level disinfection. So there I found that very often the pre-cleaning part was a very big blind spot. People had no concept of that need to do pre-cleaning. And everybody talks of what cleaning is done in the reprocessing area, but the pre-cleaning area, that was a big blind spot. And that biofilm that forms initially, if you don't do a good pre-cleaning, then a lot of your high-level disinfection is going to be rendered pretty useless. So that was one big blind spot that even in big centers, it is often missed. The second thing I felt was the attention paid to how clean are your transport carts, how clean are your scopy cabinets, how clean are how good is your post high level disinfection drying of your scopes, because these are all areas or gaps wherein these are all blind spots that are again account to be blind spots wherein issues can creep up in endoscopy.
So could you give us more highlight by sharing the pre and post study variation after the ENDOSAFE program? Could you, we would like to see the pictures, and could you take us through a PowerPoint presentation if it's fine?
I'll just share the presentation. So is this visible to everyone?
Yes, yes, sir.
So at the outset, I would like to thank Pari sir and the Kaho team and Barnali and the ASP team for giving me an opportunity to share my inputs. I am not an expert in quality, but whatever I learned is during my journey in endoscopy and during this ENDOSAFE process, I did learn a lot. And I'm just here to share some of my insights. So this is a small presentation. And so we are a 1,200 bed teaching hospital that has a lot, almost all the broad and super specialty departments located in the outskirts of the city of Mangalore. This hospital began with the aim, the vision of the organization was to build a humane society through excellence in education and healthcare. And it encompasses the whole university, the NITTE University. And we, Justice K. Segde Charitable Hospital is a part of NITTE University. It encompasses 3 campuses, 44 institutions, and has around 27,000 students in different specialities. And this is the first school where the thing started. And these are 2 inspiring figures. The inspiration comes from Justice K.S. Hegde, who was the former Justice of the Supreme Court of India, and Chancellor is his son, Mr. Vinay Hegde. And they both, with the idea of service and quality, this hospital began in 1998. And the Department of Gastroenterology began in the year 2017-18. We began with 2 gastroenterologists, and this was our growth in terms of OP, IP, and procedures over the past 7 years. And we've recently evolved into a Center for Digestive Disorders, which is a lot more comprehensive. These are the scope of our services. We treat both adult and pediatric patients. We do a lot of diagnostic and therapeutic upper and lower GI endoscopy. We do a lot of ERCPs, endoscopic ultrasonography, both diagnostic and therapeutic. We have a very busy GI physiology lab that deals with a lot of esophageal and anorectal manometry and motility studies. We do a lot of pH studies. We also recently ventured into third space endoscopy. And we've already been doing a lot of small bowel work, some fibroscan, cholangioscopies, and are in this process of starting these as a full-fledged service. So all in all, we do cover a large gamut of procedures. We do a large variety of procedures and cater to a large number of patients. So the agenda for today was why endoscopy safety matters, our journey, what are the challenges we faced, how we overcame them, and how we felt it had an impact on our quality and patient safety. So one of the important aspects to remember is endoscopes are semi-critical devices. They are carriers of pathogens, and if cleaning is not adequate, they become a source of infection because of inadequate reprocessing. Particularly, we are seeing a rise in the number of infections. There was also a lot of infection related to ERCP scopes, even in US, in spite of best cleaning standards. So this is something that's well known. And outbreaks often stem from biofilm buildup, particularly pre-high-level disinfection, defective channels, and contamination during automated washing failures, as well as during the drying process. So I covered the blind spots. I won't spend much time on this. So I'll go into what were the challenges we faced when we began. So initially, when we began our endoscopy journey in this hospital, we had just one single endoscopy room. The biggest challenge was the growing number of patients and the delay in completing the cases. We had a very small makeshift area. I'll run through in the video, which was adequate but not ideal. More number of cases meant often the technicians would rush through with the entire cleaning process. So these cleaning processes were not very thoroughly audited. The other common issue that we faced was we had a common entry. There was no unidirectional flow. There was a common entry and exit point for the scopes, which increases the chance of cross-contamination infection. It was a small recovery area with lack of privacy. There was also a lot of inconvenience with the fact that the endoscopy and rooms and the OPD for gastroenterology were located in different spaces, making it highly inconvenient both for the doctor and the patients to shuttle between the 2 areas. And we did not have a common billing area, which caused unprecedented delays to daycare patients and overall reduced the satisfaction and created a lot of confusion. So with this in mind, we decided we had long in mind that we needed a dedicated endoscopy area and a dedicated endoscopy suite. So we were in a discussion with the team of from Olympus who had supplied us the endoscopes, and Mr. Santosh Babu from Olympus and Mr. Sharanan from the ITPL company, which takes care of the CDS aspect, had helped us in this new lab that we've set up. NABH was already implemented in our hospital. So we were an NABH accredited hospital and had fulfilled those requirements. ENDOSAFE came in at this point when we had just were on the verge of moving into our new lab. So I'll just quickly run you through a short video that shows us our pre and post lab. This was initially the old endoscopy suite. It was a single room and quite congested and crowded with a lot of equipment piled up. Makeshift cleaning, disinfection, and storage area, and a congested recovery. And this was our new lab where we had a dedicated reception billing. We had the OPDs for the medical and surgical gastroenterologists located in the outer aspect of the lab. And we work together with our surgical gastroenterology colleagues together under the umbrella of the Nitte Center for Digestive Disorders. And subsequently, we set up the other aspect. This is the clean corridor, wherein there is no movement of any contaminated scopes in this corridor. We have 3 endoscopy suites, which are all linked on 2 sides, from the clean corridor and the dirty corridor where scopes move. And we have a motility lab and a cleaning disinfection room. We also have an AV room where all procedures can be relayed live, and from here can be relayed to outside centers for teaching and demonstration. This is a motility lab. This is another endoscopy suite where procedure, and this is the dirty corridor where scopes once used then get moved into the CDS room, and this is the CDS room. The scopes then go into either manual or automated pre-cleaning and reprocessing. So we have 2 AERs, and once the scopes are cleaned, they are dried and stored in these storage cabinets. We also had installed an IVOS station subsequently to fulfill the requirements of ENDOSAFE. This is a large, spacious recovery room with 14 beds, wherein patients are monitored pre and post procedure. There's also a technician and a doctor's lounge for the relaxation between procedures. So our journey began initially at this point of time with an internal audit, and whatever the gaps that were noted were then taken into consideration. SOPs were created, and subsequently we had implemented this. So what were the challenges we faced initially at the end of the initial audit was we did not have an IVOS station. Call bill for individual call bills for individual patient beds in the recovery room were not installed. Visible fire evacuation plan was missing, and an absence of systematic outbreak investigation policies were lacking. The staff were all not trained in BLS and were not BLS certified, and we were routinely not, the key performance indicators were not being routinely monitored. So these were certain gaps that we had found, and subsequent to the audit, initial audit, we made sure that these gaps were all closed. IVOS station was installed, call systems were installed, the exit plans were installed, and outbreak policy was implemented. Monthly IPC meetings were initiated. All staff members were trained in BLS. SOPs were prepared and implemented. KPIs like the bubble preparation scores, the scope withdrawal time, all of these were closely tracked and monitored and implemented. A QR feedback code was implemented, and chemical spill kit, which was absent, was also implemented. So all in all, what I felt was we were doing a pretty decent job, but these things helped us look at what was missing in our system, and then we could implement this. What this has definitely done is I felt it has definitely helped with the whether it's the patient feedback system, or whether us tracking how much time we're spending in our colonoscopy, how adequate is the bubble preparation. All of these are now on the reports. Our reports are more standardized. So with all of this, I think definitely it has brought our staff and our doctors more awareness, and we feel that it's definitely helped us and our patients in getting some standardization into our endoscopy suites. So to conclude, I'd say ENDOSAFE implementation helps us in our infection control, staff preparedness, patient satisfaction, and also in the environment responsibility. It's been an eye-opener in many aspects. And as the adage, my boss used to always say, well begun is half done. So we are happy that we've begun in a good manner, and we hope that we are able to continue forward in the future. So thank you all.
Thank you, sir, for that insight. And the pathway especially was well demonstrated in the video, and I'm sure that has made half of our job much easier. And blind spot, as we know, often make the difference between the good practice and safe practice. To conclude, now let's now move to Dr. Deepthi. Infection control is a very heart of endoscopy safety. Could you share us how the ENDOSAFE program has helped to reduce the infection control risk, address the operational challenges, and streamline the reprocessing practices?
Thank you, Dhanya. That is a multi-pronged question that has spears coming out of all sides, but you have asked a very relevant set of questions. So the thing is, endoscopy as a unit is dealing with two of infection controls nightmares. One is single-use devices. Reprocessing of single-use devices is done in a very high quantity and very high frequency in most of the endoscopy units. So that is one of the nightmares that we deal with in infection control. And the second thing that we are very wary about is, this is a unit where, as per Spalding's classification, semi-critical instruments are being used in very high frequency, and it is an absolutely indispensable part of the endoscopy unit. So high-level disinfection automatically comes into play. So high-level disinfection is something that is not as easy to monitor as your sterilization process. The multiple checks or the automatic systems and cycle parameters are lacking in high-level disinfection. So the way you do it also matters. So these two aspects, which are very critical from the infection control point of view, where endoscopy is concerned, is addressed very effectively and very elaborately in our ENDOSAFE standards or criteria and requirements. To begin with single-use devices, it's not just about documentation of single-use devices, it's about how you make it safe, how you make the use of reprocessing of single-use devices safe for the patient, safe for the institution, and still maintain its functionality, how to ensure its functionality. And all of these parameters are clearly mentioned one by one, so that even if your aim is just to clear the certification, automatically you'll fall into the trap of doing things the right way. You may not be committed to begin with, but in the journey, you turn to be a committed person. So single-use devices are addressed very effectively in these standards. And the second thing, where high-level disinfection is concerned, this is the, when we preach high-level disinfection, we become enemies of two sets of people. One is the endoscopy team, and the other is the enemy of biomedical engineering department, because sometimes when we are out in the hunt for microbes or out in the process of elimination of microbes, one or the other person subjectively may do things a little over enthusiastically. If it is not used in the manufacturer recommended concentration, what happens is the damage of the instruments on the other side. And then the biomedical engineering department comes and, they'll be all in a strangling mood to get their hands on the infection control team. So this is where our ENDOSAFE guidelines very clearly say that high-level disinfection should be managed in a manner such that it is safe for the personnel. Yes, MSDS has met everything, and it should be safe for the instruments also. So this helps us, or helps the unit in walking through the tightrope, balancing disinfection. Yes, high-level disinfection on one hand should be balanced, and on the other hand, balancing the safety and the health and the life of the endoscope itself. So yes, two of those very difficult to achieve tasks are very carefully elaborated, and it will take a person who is journeying through the standards right through to the other end in a safe manner.
Thank you, Deepthi. And all of you know that Dr. Deepthi is an ASCA surveyor. So I've got great idea about the systems and process both within and outside the country. So tell me, in your view, what is the most underestimated aspect of endoscopy audit?
The most underestimated aspect of endoscopy audit would be, when we talk about the high-reaching standards or the high-reaching elements, we may forget the simple things like availability of hand hygiene. Now, endoscopy is a unit where the oral and the GI tract is being handled and manipulated a lot. This is an area where I would restrict the use of hand rub and would insist on hand wash. So the presence and availability of hand wash cannot be emphasized enough where a GI procedure is concerned. That is one thing. And another thing is, like I said, there is a lot of nitty-gritty. There are a lot of nitty-gritty details where endoscopy is concerned, where the journey can go a long way if you address the smallest matter. And in these things, the commitment of top management and top leadership will take us a long way. So that is another aspect which is included. That is the first standard in infection control chapter of ENDOSAFE audit. Because where infection control is concerned and the nitty-gritty in endoscopy unit services is concerned, we need a diverse leadership with top management representation, because the smallest decisions can take us the longest way. So it may look like just one standard, but on that one standard, everything in infection control and reprocessing will revolve and pivot around.
True. So the culture of the organization largely is shaped by the top manager. At the same time, even second level managers also have an equal role to play. That's so well put. And while we are on the subject of practical challenges, let's turn to our audience for a moment. So if you could change this one question, if you could change one thing in your endoscopic unit workflow tomorrow, what would it be? You can share your thought in the chat or chat box. Yeah. So the question is, if you could change one thing in your endoscopic unit workflow tomorrow, what would it be?
I think Meenakshi is raising the hand. Is it for this question or some other reason?
Good management. Proper drying and storage. Excellent. Hand washing, yes, Deepthi has mentioned. Requesting everyone to answer, yes. Hand washing, reprocessing. It's more or less revolving around the infection control practices, best infection control practices, and then the reprocessing. Okay, environmental cleaning. Indicators. Okay, quality indicators. Yes, surveillance aspect. Yes. Requesting the panelists to pay attention to the answers because we'll have to address these things carefully. Yeah, thank you so much. Now, moving forward, Madam Barnali, you have had direct experience in ENDOSAFE tools supporting various endoscopic units. Could you walk us through how it has simplified the complex workflows and helped the team to work towards compliance and patient safety?
Yes. So when it comes to the tool, I would say it's a very transformative tool. Like the practice which we all are discussing now, or what is coming up on the chat, it is one thing which is a concern across, right? So it is a tool that breaks it down into structured checklist-driven framework that makes workflow, it makes workflow simple, standardized, and very easily to, I wouldn't say that easy, but it is always a mindset that makes things easy or tough, but it got easily adopted. So that's one thing which I would say. And what sets it apart is it does not limit itself only to reprocessing. It takes care of every aspect of the endoscopy unit, starting in from the facility design, the infection control, like Dr. Deepthi put across a very simple example, like I do the reprocessing rightly, but am I doing the basic infection control? Am I getting the environment cleaned every time, the surfaces cleaned every time a patient walks out, or the patient moves out from after the procedure? So those nitty-gritty infection control practices, understanding, like when we walk in and we say you need to consider the environmental factors as well. Check on your water. They would fall from the sky, like they are falling from the sky. Why water is needed? Of course, water is needed. I do everything right, and then the water becomes a source of giving me an infection is not what is correct. So what sets it apart is that it does not restrict, as I said, only to reprocessing. It addresses every aspect of the endoscopy suite. So it addresses environment safety, facility design, medication safety, infection prevention, and a comprehensive approach. Wherein, when we walked in with this tool, it was for the hospitals. We saw it out during KahuCon 2025. The kind of happiness which was there, something that everyone achieved, that spoke volume about what is there in the tool. Like, it was more of receptive. And trust me on this, many walk up to us and ask that why didn't you reach out to us? Why this tool never reached out to us? So this talks high on that. End of the day, every one of us are keeping the patient at the center and wanting to do things, wanting to adopt practices which would build patient safety. So wherein in the endoscopic suite, Dr. Chandrashekhar is here. We all understand that it is more of a clinician-driven department. But there, when the tool walked in and the tool was shared, it was very, they were receptive and they adopted to it. So that is one win which we see. And over now, when we see the registrations coming in and the requests reaching us, it talks volume about why hospitals should adopt ENDOSAFE. And definitely the certification on the wall, which Parisar very rightly mentioned, is one thing which feels good for anyone walking into that department. As a patient, if I look in, I would look up to the wall and say, okay, they are quality. They talk of quality. They talk of patient safety. So that's the aspect which I would bring here when it comes to the tool.
Thank you, Ma'am Barnali. That was very illuminating. Earlier, the focus was just on reprocessing.
Exactly.
Now we understand it encompasses a gamut of multiple elements and domains. So that was a change. Now, to complement this, I would like to invite Dr. Pari. Sir, if you are asked to create a checklist of top 3 must-do actions in any endoscopic unit, your non-negotiable, what would they be?
That's a difficult question. I think I would, being the chair of ENDOSAFE, I'll say all the things. But I think though you said, it not only addresses reprocessing, I would put that top of the list. Okay, rigorous reprocessing protocols, whether you're doing it manually or automatic, it does not matter. So that is the top priority of any endoscopic unit because, and as Dr. Chandrashekhar pointed out, immediate pre-cleaning. So the blind spot he spoke about. So that, the pre-cleaning has to be done, at the place where the endoscopy is done. So that is where many people miss that out. And then the leak testing. That is another. It's such a simple test, but it's not done every time. So we need to do it every time we took this scope out of the patient, the leak test has to be done. And of course, people think that manual cleaning is a chore and, we all aspire to have the AERs, endoscopic, but just putting the scope in an automatic thing is not the end of the story. So we need to really make sure that, we got every step of it right. And more important, especially in our country, is the drying. Now, many of our places have high humidity and a propensity to form, fungal infections and fungal growth. So how do we keep that, out of the drying cabinets? So these are all various aspects which the ENDOSAFE talks about when you talk about the reprocessing. And the second point of the reprocessing is, of course, patient safety. So how safe is your patient when you're doing an endoscopic procedure? Are you doing it for the correct patient? Starting from there, the patient identification, how good is your consent process? And if you're doing it under moderate sedation or under GA? How is the pre-anesthetic assessment? How is the monitoring during that procedure? And simple things like after colonoscopy, how near is the toilet? No, I'm really glad that we looked into all of these things in ENDOSAFE. So the convenience to the patient after a colonoscopy. So all these things, not only patient safety, but patient comfort and privacy, I think is the second point. The third is, I think the staff are as good as the training. So your training, continuous training, and is the third most important aspect which I would focus on. So if you look at three things: reprocessing, patient safety, and your training, how good it is, how good is the evaluation of competency for your staff. As Dr. Chandrashekhar pointed out, we never thought about BLS certification for endoscopy units. I think that comes as a surprise to many units. And you would have remembered, Dhanya, that we got many questions on this. Why should we, do that for our unit? So, and incident reporting systems. Because the endoscopy is always tucked away in one corner of the hospital. So does the incident happening in the endoscopy come out to the quality team and talked about? So I think these three things are probably the most crucial aspects of endoscopic safety.
Now let's check the memory of our audience. Tell us the 3 points what sir mentioned. Let's give 1 minute time to our audience to answer the top three must-dos.
That was a googly then, yeah? I didn't think anybody expected that.
No. People are really good. Reprocessing, yes. Yes, see, sir.
Incident reporting also has come up.
Yeah. That was a bonus point.
Yeah, I think many of them have got it right.
Yeah, many of you have answered. Yes.
I'm happy
Thank
because
you.
I thought my explanation was clear.
That is right. Thank you, sir. Thank you, sir. That was practical, concise, and powerful. So now I would like to involve our participants once again. So the next question to our participants is, what do you see as the biggest challenge your unit faces in maintaining endoscopy safety? What do you see as the biggest challenge your unit faces in maintaining endoscopy safety?
Yeah, cleaning of delicate endoscopic camera. I think that's a good one.
Yes, lack of knowledge, training, experienced staff, infrastructure.
Manpower and training. Time constraints. I think that's very good. It's a common thing in many units. So no proper hand wash, consultants not following aseptic technique. Staff not trained. Yeah.
Here we get the clues for next round of questions.
Lack of clinician-run department.
Increased world. Water bubble removal. Okay.
Very practical. I think people. The day-to-day challenges are coming out actually.
Okay. Thank you so much. Now, to add some energy as we near the end, let's have a rapid fire round with our panelists. So the question is common to all. One improvement you would recommend for an endoscopic unit starting from tomorrow in just one sentence. So the first, Dr. Chandrashekhar.
Yeah, I think, see, though I would have always said the one improvement I always looked at was unidirectional workflow. I think that solves half your problem. As sir said, that precludes a lot of people from joining in. But I would say getting your at least your three-step, your immediate pre-cleaning and your basic cleaning, training your staff in that. Because I see most of the staff are not trained. Most of our endoscopy technicians have no proper certificate course that they've done. So at least teach them pre-cleaning and proper level of HLD, the basic washing of the scopes and drying. I think that is the one thing that I would say.
Okay, so pre-cleaning and training of the staff. That's a
Or
good point.
washing. Basically, yeah.
Washing. Okay, thank you, sir. Dr. Deepthi?
One advice that I would give is to follow the standards. In the beginning, you may not understand what the standards are all about, but understanding that it comes from a resource pool that is strongly researched on the topic, just follow the standards through and the commitment will follow.
Brilliant. Barnali, ma'am?
So for me, one thing which I would say is, apart from everything, leak testing and every other thing, you should know the chemicals that you are using. Knowing the chemicals is very, very critical. So one, that would be my one statement for all of them. Like whether it's a high-level disinfectant or the cleaning agent, you need to understand your consumables or the products that you use.
Exactly. I must also add this instruction for use, IFUs. Importance for,
Exactly. Yeah. Instruction for use is very, very important, be it for the chemicals or be it for even the automated endoscope units or the scope. It is very critical to know those documents, all information sits there. So
Very good.
that's one thing which I would ask everyone to.
Thank you, ma'am. Dr. Padi?
I think I would dream of having a clinician who understands endoscopic safety. I mean, Dr. Chandrashekhar is a dream.
One.
Yeah.
Right. So we are every day fighting with clinicians who don't actually understand the importance of the endoscopic quality and safety. So that is something which, as a clinician, I appreciate. And that is my mission actually. Now, everywhere I go, I keep telling clinicians should get involved in quality and safety. Because a clinician-led quality and safety program will definitely succeed. If that clinician is not involved, it's not going to be there, 100%. That's what we have seen. And so I think that's something which I would want.
Exactly. Deeply insightful, Dr. Padi. So that's the end of our panel discussion. I request our audience to please share your questions in the Q&A box or even in the chat box. We can take one or two of our panelists.
So you said there are some prizes at the end. Have you forgotten?
No, that is Kahoot. We are at to.
Oh, okay. So
One
I
second,
think
sir.
the audience should wait. No, we still have the
Yeah,
best
they
part
should.
waiting.
They should have.
Yeah.
They should wait. Okay. So let's check for if there are few questions. Yeah, there's one question from Ranjini. High-level disinfection pH strip, everyday checking, is it required or not? I think to Dr. Deepthi.
High-level disinfection strip should be done on a daily basis. Daily basis meaning on the days where you have a procedure, do it. If there are 2 days on which you do not have a procedure, Saturday and Sunday, there is no point of doing the pH strip and documenting it. Be logical, lead your processes through logic. Whenever you have a working day and a procedure line, you should do the test and the strip should pass before you proceed with that particular disinfectant. If it does not pass, it should be changed. That's all. And if for 14 days you have not used it, there is no point in checking the pH strip on the 15th day. Whether you use it or not, once it is in place, on the 15th day, it should be changed.
Okay. So the next question is from Suganya. So the question to Dr. Padi, for pre-cleaning and post-cleaning, do we have to use RO water or NS?
I think, RO water is good enough if you have it. But if you're using tap water, if RO water is not available and you only have tap water, then I think best is to use the normal saline. Dr. Chandrashekhar, will you agree with that?
Yeah, I think ROs are way to go. I agree with that, sir. And I think since you brought up the clinician part, that's something I've noticed. I think for whoever, I think we see 140, 150 people attending. And I think they're all quality managers now. I have one request to all of them. Please go today and tomorrow and tell your consultants that you're registering for ENDOSAFE. Don't tell them before the audit. So please go and tell them and get them involved. I think that's very important. So they also get keyed into it. But
Yeah. See, that is another problem. You brought a very important point there. Clinicians would like to get involved from the beginning. It's very irritating for us. I'm talking as a clinician now. If you do all the process and come in the end and say, tomorrow is the audit, and I'm kept out of the loop. That really frustrates many clinicians.
So I think the next question could be answered by Dr. Chandrashekhar. It's from Sagar Chandrashekhar. What is your view on disposable endoscope?
I don't think that is a real practical thing that is going to. It has. I mean, they had disposable duodenoscopes that came in the US. See, in India, most people pay out of their pockets, and few have insurance. So I don't think disposable endoscopes are really something that we foresee in the near future, unless it is something like a cholangioscope or something which is designed to be single use. Even in which case, many times we have to reuse them after because of the cost. So I think the focus is always going to be on proper reprocessing. I would not be thinking.
So before I hand it over to Dr. Padi, let me brief you all once again about our upcoming activities. So the last date for submitting the application for auditor training is on 30th of September 2025. And the hospital registration for ENDOSAFE certification, the last day would be September 2025 again. And now I formally conclude today's enriching discussion, and I would invite Dr. Padi to deliver the vote of thanks.
Thank you. Thank you, Dhanya. Preeti, can you shut that? Thank you. Again, first thanks is to Kaho for again bringing in such a wonderful ENDOSAFE program, and also for organizing this webinar. And say next is to the participants. Now we had enormous response for this particular webinar. Thank you each one of you for attending this webinar. Special thanks to Dr. Chandrashekhar for taking time out of your busy schedule to be part of this webinar and sharing your insights and also sharing your journey before and after ENDOSAFE. Thank you so much, Dr. Chandrashekhar. And I want to thank Dr. Deepthi, who gave her insight as a from the point of view of microbiology and infection control. Thank you so much, Deepthi. And of course, if I forget the Kaho team, I would be, really forgetting something very important, especially Preeta, who's done all the heavy lifting. Thank you so much, Preeta. And Meenakshi, who's been the support and anchor for all our activities. And of course, by proxy, thanking Dr. Lalu and Dr. Vijay for giving us this fantastic platform called Kaho. Thank you so much.
Thank you, sir. With that, we bring the session to a close. A big thank you to our distinguished panelists, our engaged audience, and the Kaho team for making this possible. Conversation like this keep us one step closer to safer, more reliable endoscopic practices, because at the end of the day, patient safety is not just a protocol, but a promise we all uphold. Thank you all once again, and wish you all a very pleasant evening.
Thank you.
Thank